As Richard mentioned, I'm the Deputy Assistant Secretary for Behavioral Health, Disability, and Aging Policy at ASPE in HHS. ASPE, for those who don't know, conducts policy research, coordinates policy across HHS, and also advises the Secretary of HHS on policy development. The office I lead, Behavioral Health, Disability, and Aging Policy, also coordinates dementia care research and policy, and we oversee implementation of the National Alzheimer's Project Act, which involves convening the Advisory Council for Alzheimer's Research, Care, and Services, and also maintaining the national plan to address Alzheimer's disease, which is celebrating its 10th anniversary this year. Next slide, please. I have no disclosures or conflicts of interest. Next slide. So what I'm going to talk about today is starting by providing an overview of the payment landscape for Alzheimer's disease and related dementias and how it influences care delivery and quality. I'll then describe some promising payment models and existing levers to support these models. And then I'll conclude by describing opportunities for further research to strengthen the alignment of payment, quality, and outcomes. Next slide, please. So to start us off, where do people with Alzheimer's disease receive care and who pays for it? So looking at the overall population of people with Alzheimer's disease at any single moment in time, the large majority, about 2/3, live at home and receive care primarily in ambulatory settings, with additional home and personal care services provided by home care workers and more often unpaid family caregivers. The remaining 1/3 are roughly evenly split between residing in nursing homes and other supportive settings, for example, assisted living facilities or board and care homes or adult daycare centers. Because this is primarily a disease of older adults, the vast majority are in Medicare, but 1 in 4 also qualify for Medicaid. While Medicare and Medicaid are important sources of coverage for Alzheimer's-related care, it's estimated that the majority of expenditures associated with this condition are actually borne by family and other caregivers, either through out-of-pocket expenses or unpaid caregiving. Next slide. Among the public payers, Medicare and Medicaid each cover different types of services and care settings. Medicare is the primary payer for ambulatory, hospital care, and post-acute care, and also plays a major role in end-of-life care through the hospice benefit. Medicaid is a payer of last resort for hospital and ambulatory care, but plays a major role in financing nursing home care for long-stay residents, nearly half of whom have dementia, and in financing home and community-based services, which in some states can include some elements of assisted living facilities. Next slide, please. Now, what I showed earlier was a snapshot of where people receive care and the major sources of expenditures at a given point in time, but what's important to note is that care settings and payers evolve a great deal as Alzheimer's disease progresses. So as people age and the condition becomes more advanced and the need for round-the-clock care increases, increasing shares of people with the disease transition from home to institutional settings, which can include nursing homes or assisted living facilities. And it's estimated that among people with Alzheimer's disease who live to age 80 or older, roughly 75% are in nursing homes. With the change in care settings also comes a change in the dominant payers. So early in the disease course, when people are at home, Medicare is the primary payer for medical services and is supplemented by private pay and unpaid caregiving to address personal care and long-term care needs. But as the disease progresses and long-term care expenses grow, increasing numbers of people affected by Alzheimer's disease will qualify for Medicaid as they exhaust their resources. Next slide, please. The features of our current payment system have a number of implications for Alzheimer's disease care delivery and quality. First, payment is typically tied to specific clinical settings, such as hospitals or ambulatory care clinics. This can contribute to challenges with care coordination as people with Alzheimer's disease transition between these settings, and it also leaves a big gap in financing for home care, which is where most people with Alzheimer's disease receive and want to receive care. There just isn't a clear funding or financing stream to support this. There's also fragmentation in care across payers, most notably between Medicaid, which covers long-term care, and Medicare, which generally does not. This can also contribute to challenges in coordinating person-centered care and in aligning incentives across the two payers. For example, because Medicaid is the dominant payer for nursing home care, but Medicare is the dominant payer for hospital care, this dampens incentives for plans and nursing homes to prevent avoidable hospitalizations. What's more, many skilled nursing facilities cross-subsidize their Medicaid-covered long-stay residents, about half of whom have dementia, with short-stay post-acute care patients whose stays are more generously covered by Medicare. So they can actually receive a higher level of reimbursement for a limited period of time when long-stay residents are readmitted for post-acute care following a hospital stay. Third is that there are big gaps in payment for home and community-based long-term care services. Medicaid is really the only significant source of funding for many, but whereas states are required to cover nursing home care in their Medicaid plans, HCBS services are optional, so they're often provided by waivers, which means they may be time-limited programs. They often have limited enrollment with long waiting lists, and services covered can vary a great deal across states. Many states also impose additional stringent income and asset limits to qualify for HCBS and can impose additional cost sharing, which can further limit access. And finally, while many patients with Alzheimer's disease prefer to remain at home, many will at some point require nursing home or other residential care, and it's important for them to have high-quality options when they do. A number of changes have occurred in the long-term care market over the past couple of decades, though, that have really shifted the landscape of where people can receive care and what those settings look like. And a couple of notable changes that I'll highlight are rebalancing efforts from institutional care to HCBS, and also the growth in assisted living facilities during this time period. More recently, skilled nursing facilities have been seeing a decline in facility-based post-acute care since the COVID-19 pandemic. Now, the combined impact of a number of these changes is that many nursing homes have been left with patients with higher medical complexity, as many lower acuity patients have either moved towards receiving care at home or in assisted living facilities in some cases. And the payer mix has shifted more towards Medicaid with lower levels of reimbursement, as patients with more resources have tended to go into assisted living facilities. So this has left a lot of nursing homes with a more complicated patient population to care for, but fewer resources with which to do it, which, as you can imagine, can create some additional barriers to delivering high quality care. Next slide, please. And then there are also some distinctive challenges in aligning payment and quality for Alzheimer's disease specifically. So to name a few examples, one is early diagnosis. Increasingly, receiving a timely diagnosis has been recognized as important to providing people with access to therapies and clinical trials, and also to provide patients and families time to plan for their long-term care needs. But in fact, fewer than half of patients with dementia receive a diagnosis from a physician. When they do, it's often in later stages of disease. And providers have cited a number of payment-related barriers to earlier patient engagement and diagnosis, including, for example, insufficient time in their clinical workflows to do cognitive assessments. Difficulty transitioning between care settings is also a particular challenge for this population. People with Alzheimer's disease are at higher risk of readmission and mortality following hospitalization, and the risk of readmission is increased among those who have unmet caregiver needs. So providing caregiver and home-based supports is especially critical during transitions, but as we've discussed, there is a big gap in financing for this. Third, as Alzheimer's disease progresses, behavioral and psychological symptoms of dementia become more frequent and severe, which leads to a need for 24/7 care that often can't be provided by family caregivers alone and is a major source of caregiver burnout. But it's very costly to provide additional home care to supplement around that, which again falls into this home-based care financing gap. And then finally, I'll just highlight end-of-life care. The current the trajectory that we tend to observe for end-of-life care among people with Alzheimer's disease doesn't really fit the trajectory and the parameters of the Medicare hospice benefit. It's really challenging to accurately predict life expectancy, so we tend to see people with longer hospice stays, but at the same time, we also see higher rates of live hospice disenrollment among people with Alzheimer's disease, indicating that many patients or their families may feel like the hospice benefit is not quite meeting their needs. But conversely, on average, people who do disenroll die within a few months of disenrolling, again pointing to these considerable challenges in matching the Alzheimer's disease end-of-life trajectory with the existing hospice benefit. Now, the combined effect of these distinctive clinical features of Alzheimer's disease and the payment landscape rely on a very heavy reliance on unpaid caregivers, which contributes to high out-of-pocket spending and, over time, a pull towards Medicaid-financed nursing home stays. And again, this might be the right care setting for many people, but our goal is to provide as many high-quality options as possible. Next slide, please. So if we asked researchers and clinicians what would be the most promising elements of payment models to facilitate high-quality Alzheimer's disease care, many would list several things. First is person-centered payment, so payment that is not tied to one specific clinical setting but can follow the patient across settings. The second is better integration and coordination across payers to better align incentives for quality improvement. And then the third is value-based payment, and a couple of specific components that tend to be mentioned are first, accountability for quality through performance incentives, but also flexibility to reimburse for valuable services that are not often covered in traditional insurance arrangements, in particular caregiver training and coaching and community-based supports. Next slide, please. Now, we actually have a number of different current payment levers that can support these goals, but to varying degrees. So these range from, on one end of the spectrum, adding value-based payment incentives to existing setting-specific payment schemes. So one example is the Medicare merit-based incentive payment system or the Medicaid value-based payment programs for nursing homes. Taking it one step further, we can look at value-based payment schemes that coordinate care across additional settings, such as the Medicare Shared Savings Program. Then as we get up to person-centered payment models, there are a number out there that incorporate some elements of LTSS. In Medicare Advantage, there are institutional special needs plans that target Medicare beneficiaries who are living in institutions such as nursing homes. Also in Medicare Advantage, in the past several years, there have been expanded primarily health-related supplemental benefits that can be used towards addressing beneficiaries' long-term services and supports needs, and special supplemental benefits for the chronically ill that can also be used to address social determinants of health-related needs. On the Medicaid side, there's the Medicaid managed care long-term services and supports plans, consumer self-direction HCBS waivers in which unpaid family caregivers can receive some reimbursement for the services they provide, so trying to address some of that gap in unpaid care. And then another example is the Medicaid Money Follows the Person demonstration. And then we get up to payment models that are not only person-centered, but also coordinated across payers. So these primarily target dual eligibles. And some examples include CMS's Financial Alignment Initiative demonstration. There are a variety of dual eligible special needs plans that integrate care across payers, including notably fully and highly integrated dual special needs plans, which also are required to offer some long-term services and supports. And then, of course, a very well-known model of this is the Program for All-Inclusive Care of the Elderly, or PACE. And then finally, one innovation I'll highlight in the end-of-life care space is the Medicare Advantage value-based insurance design hospice benefit. So the CMS Innovation Center is currently testing, as part of its VBID model, a hospice carve-in option where beneficiaries can receive palliative care, transitional concurrent care, and supportive services without disenrolling from Medicare Advantage. And currently, CMS is evaluating whether this improves quality and coordination. Next slide. So there's still a lot we need to learn, however, about how these different types of payment opportunities and levers can better align with quality and outcomes for the care of people with Alzheimer's disease. So I'll highlight a few areas where more research would be valuable. So the first is that we have very limited evidence right now on the impacts of value-based payment on people with Alzheimer's disease specifically, which is quite a gap given how significant a population this is. Also, outside of PACE, we have limited evidence on how various types of integrated care programs, for example, the dual special needs plans, are serving people with Alzheimer's disease and their outcomes. We have less evidence on assisted living facilities. Now, while these are largely private pay, and so we don't really have an effective payment lever, patients in assisted living facilities are still receiving their ambulatory and hospital care paid for by Medicare, and eventually a number of them are transitioning to Medicaid-financed nursing home stays. So this is an area where it behooves us to understand a little bit more about the type of care people are receiving and opportunities to improve quality, but the evidence base in this area is fairly limited. Next slide, please. What we could also really use is more evidence to help guide states on their HCBS program design. In particular, which HCBS waiver designs best support the delivery of evidence-based Alzheimer's disease care? How do these designs influence quality and outcomes for people with Alzheimer's disease? And what is their impact on nursing home use and total expenditures to help guide states on their rebalancing initiatives? Also very important is how these payment levers differ in their effects on equitable access and treatment, and in particular for communities of color disproportionately affected by Alzheimer's disease who experience disparities in care at every stage of the Alzheimer's disease trajectory. And then finally, there's a real need to better understand which payment models can improve the quality of end-of-life care. And the Medicare Advantage VBID model may shed some light on this, but likely will not be the last word on the subject. Next slide. And then the final question I'll raise, which I'm sure Bruce and my fellow panelists will have lots to comment on, is whether payment system reform is enough to get us there alone. And I'll highlight a couple of examples of potential limitations for what payment reform can achieve. So first, the PACE model contains many of the desired elements for payment and delivery of care for Alzheimer's disease, but we've seen adoption be very limited across states by many other hurdles not related to payment necessarily. For example, the high regulatory barriers to implementing a PACE program.
I don't want to interrupt, but the regulatory barriers are the least of the barriers.
Okay.
As someone who spends 10, 15 hours a week trying to develop PACE programs, it's the least of it.
Excellent. Well, I can't wait to hear more. And then another example, just to highlight, is in recognition of the challenge with early and timely diagnosis for Alzheimer's disease. In 2017, Medicare adopted cognitive assessment and care plan codes to try to incentivize providers to take the time to do a cognitive assessment and improve earlier diagnosis. But recent evidence suggests that use and uptake has been very low. So why is that? This is an example of a case where, from a payment economist viewpoint, the system has attempted to do the right thing, but we haven't really achieved the desired outcome. So I think the key research question is also what combination of payment delivery system and regulatory changes are needed. Next slide. That's all for me. Thank you so much.